Hello, this is the recorded lecture for Chapter 2, looking for information technology for health professionals. And in this chapter, we're really going to look at what's called medical informatics. So that's really looking at how we get information on medical care, delivery of medical care, the quality of our medical care. And we're going to look at the American Recovery and Reinvestment Act. We're going to look at high tech and the Health Information Technology Decade. We're going to look at all of that together with this in this chapter, sort of set the framework for where our technology is. So when we look at what's called medical informatics, what we're really saying is that medical informatics has lots of definitions. It's really different to anybody who uses the terminology. Commonly what it means, it's used to define the technology to organize information in healthcare. So in one mechanism, we look for how we collect information, and in another look, we look at how we measure that, if you will, and we go from there. So one is collecting, one is delivery. So medical informatics focuses on using computers to organize information to improve our diagnostic images and image-guided and minimally invasive surgery, to develop simulations so we can use those to train our healthcare providers, and develop low-cost diagnostic tests. So informatics is an ability to make that better. Medical informatics also focuses on using computers to organize information so we're able to better treat physical handicaps. We can provide consumers with digital information versus hard copy information, or both. And we can coordinate what's called international medical reporting, so we can start to collect data to look at trends in healthcare and diseases. Medical informatics also focuses on using computers to organize information to develop and improve information systems, so we can better sample our data and make some decisions as to what maybe the certain disease is rising, or maybe some symptoms, maybe certain symptoms of a disease are changing, and so we can start to look at those. And we develop these decision support systems that help us to be better at the diagnosis. Now, some specialties include bioinformatics and dental informatics and nursing informatics and public health informatics. So we have different subgroups in this medical informatics world. Now, the American Recovery and Reinvestment Act, or ARRA, included billions of dollars for the expansion of health information technology. And what it did is it offered significant monetary incentives through Medicare and Medicaid to doctors and hospitals, so they would develop an electronic health record system. In fact, in some cases, they made it detrimental as far as payment to do that. They would deduct payments if they did not become electronic as far as their healthcare records are concerned. ONCHIT, the Office of the National Coordinator of Health Information Technology, was established in 2004. And its mission is to provide leadership for the development and nationwide implementation of an interoperable health information technology infrastructure to improve the quality and efficiency of healthcare and the ability of consumers to manage their care and safety. And it's funded by ARRA. What this really means is that it's to make our information more portable, so that if you live in one town and you go visit somewhere else and you need health care, they're able to pull up your information and adequately treat you. And that's really the issue, is being able to see your background and pull it up. Now there's people get worried about privacy and security and all that kind of thing, but the truth is that making your health records portable is a very important element in reducing healthcare error due to people on vacation or traveling. ONCHIT has this task of overseeing the adoption and meaningful use of electronic health records, setting those standards, and judging the impact. So they have to measure the outcome. The goal is the universal use of EHRs by 2004, along with establishment of health information technology infrastructure. And again, it's 2016 instead of 2014, and we are almost there. We are probably 80% invested into the use of electronic health records. Now, when you look at Medicare and Medicaid timeline, we see that HHS developed interoperability standards in 2009. They start to set those standards, and so Health and Human Services, by the way, and that they include CMS, which is Centers for Medicare and Medicaid. They fit inside of the HHS, Health and Human Services system. And then Medicaid incentives began. So in 2011, we started giving Medicaid incentives, and we started seeing those incentives. We started seeing the phase down of those incentives, and then we started to see non-hospital-based physicians in their first year. So we're starting to see hospitals being resolved, and then we're starting to see physicians' offices getting involved in that electronic health record. So we're going to see that. So we get out to 2021, we should basically be a totally electronic health record system. Now, the use of EHR in 2011, we are 25% of the doctor's offices and 50% in hospitals. And like I said, right now that number is much closer to 80% for hospitals. Health Information for Economic and Clinical Health Act, HITECH it's called. It seeks to improve American healthcare delivery and patient care through unprecedented investment in health information technology. So we're investing in using technology to improve the quality and consistency of our healthcare. The provisions of HITECH include work together to provide the necessary assistance and technical support for providers, to enable coordination and alignment within and among states so we can start to share information state to state. That's one of the big issues right now, is that states, all licensure for all healthcare is state by state. So if a healthcare provider lives in one state but practices telemedicine in another state, he or she needs to also have a license in the other state, the second state, which is very restricting. So the question is whether we should have national licensure for doctors and nurses and PAs and health nurse practitioners and such. We should have licensure for all of them, which is on a national level instead of a state level. And there's a lot of, you know, you have to think about state rights versus national health care. So we have to start thinking about what makes more sense. So provisions are to establish connectivity to the public health community in the case of emergencies. So if we have a national emergency, we can respond to that if it's across state lines, and they always do. Assure that the workforce is properly trained and equipped to be meaningful users of electronic health records. So we are collecting information properly, inputting it correctly. Now HIT, Health Information Technology, 2 years later, the impact of the Recovery Act, as far as Health and Human Services.gov 2011, the funding levels below for improving and preserving healthcare, health information technology, and children and community services are actuarial statements as of January 2011. And what we see is that improving and preserving healthcare has really, we spent up to $100.3 billion in doing that. We spent about $22.6 billion in health information technology, children and community services, and you'll see the term SCHIP, which is also involved in that. That's the healthcare for children. That's about $13.5 billion. And sadly, but our scientific research and facilities is only about $10 billion. Community health, only about $2.8 billion. Comparative effectiveness research, about $1.1 billion. Prevention wellness, which is should be more, is about $1 billion. And accountability and IT security is about $0.1 billion. Make that $1 million. So these are the funding levels for the different levels of that HIT. Now HIPAA, Health Insurance Portability and Accountability Act, was passed by the United States Congress and signed into law way back in 1996. The goals of HIPAA were to make health insurance portable from one job to the other, so that your health insurance didn't go away, if you will, or if you will, the health insurance was portable from job A to job B. It was also to secure the privacy of medical records. And HITECH extends that privacy rule and increases the penalties for violating that. So making your information portable, but having great penalties if somebody violated security and privacy. Now, patient information form includes your personal data, your medical information, and your insurance information. So it's a pretty succinct, extensive piece of form that covers lots of information. Now, the paper medical record, the traditional patient record was a paper stored in one doctor's offices. And the problem with that is that paper medical records could be unreadable. They can lead to serious errors in diagnosis, treatment, and billing. And in fact, we saw that in medical error. And there's only one copy, so if something happens to the doctor's office, let's say the doctor retires and all of the paper is thrown away or whatever, you lose all that information. Or let's say the doctor's office gets burnt down or something else happens, you lose that information. So that's a pretty significant problem along using the paper record. With electronic medical records, which are encouraged by HIPAA and the federal government, electronic medical record is very slowly replacing that paper record. The EMR is a record of the patient at one healthcare facility, and it belongs to that facility, but it's also stored off-site. It's called duplicative storage. So they have an off-site location. So if that building gets destroyed or that IT system gets destroyed, there's another place that the information is located. The information on a patient's EMR will form the basis of the electronic health record. An electronic health record is an electronic record of the patient health information, and it's generated by one or all the encounters that are associated with that delivery of care. It includes information from all the healthcare providers and institutions that give care to the patient. So it's a consolidation of all the care that that patient has had at in that one place. Now, ideally, the electronic health record is not the property of one institution or practitioner. Well, that's not really true at this point. And getting your information for your health record, though you can do that, is not easy. You have to put in a specific form, and then they charge you to make the copies. I mean, it's pretty involved. And so it's not as easy to obtain as you might think. And there's no penalties for institutions that don't give it to you. And then you can sue them and get it eventually. But that costs you money. So eventually it must be interoperable nationally as well as international. So because if you go out of the country and you decide to go to Europe, then your medical records can go with you. Again, can carry that portability. So we look at the electronic health record. What we see here is a nice outline here, a good snapshot. We can see the different mechanisms that are covered. You can see all of that. Looks at your pictures of your disease, maybe your X-rays, some of the maybe an endoscopy, if you will. You can see the actual photos. So all that's carried, continued inside this health record. Now, the meaningful use of electronic health records is defined by ONCHIT, and it refers to meeting the required 15 criteria and meeting 5 out of 10 other criteria. So it has to match all that. Patients' demographics, vital signs, up-to-date problem lists, active medication lists, and active medication allergy lists are among those required. So those have to be carried, and those have to be portable for the patient. The certification criteria were developed by the Secretary of Health and Human Services, HHS. I believe that was Tommy Thompson way back when. And the meaningful use criteria may be adopted over a 5-year period. So it's really important that EHRs are able to do that. Again, this is a medicine electronic record being the criteria for meaningful use. So it is able to pull in information of recent vital signs, if you will. You can look at all the different areas that are covered by those criteria. And you see the next step as we look at that, if you will, office visits and such. This is looking at, what we're looking at here is really the student edition of that. We'll probably see some of that if you ever take the health record class. But it looks at what you do. You look at the temperature, it puts all the vital signs in, and it saves those for future use. This is another look at we're looking at common cold. We see that's the diagnosis. We see what the exam was. We see the treatment and all of that. And then we have a printed encounter. So we print this out and say, okay, if somebody needs information, this gives a copy of that information in hard copy. Now the National Health Information Network, NHIN, is to be effectively improving care. EHRs, electronic health records, have to be fully interoperable. That means they have to have the ability to communicate with each other nationally. So they have to use the same criteria, the same digital information mechanisms and standards. So regional cooperation is being fostered to the establishment of regional health information organizations, or RHIOs, in which data can be shared within a region, an area, if you will. Now, the National Health Information Network, NHIN, is an infrastructure that would allow communication between those RHIOs. Now, computer information systems in healthcare. Computerized information systems are used in some hospitals and other healthcare facilities that help manage information and help the organization to establish relative information and to measure that, so they can go through, they look at diseases and treatments and success of those treatments. So if 10 providers do something and 8 of them are very successful and 2 of them are very unsuccessful, they can see what the differences is in the quality of treatment. It's also to receive the full benefits of computer technology. Each of these separate information systems needs to be linked together. So your lab information, your pharmacy information, your X-ray information, radiology information has to be all hooked into this. So this is a communicating system with what's called PACS, which is a picture archiving and communication system, which is electronic digital collection of radiology data. I have to tell you a kind of a funny story. I was an administrator at the University Hospital in New Mexico Hospitals Medical Center, and we put a PACS system in, and the emergency room doctors just didn't want to do it at all. They were so angry about it because they couldn't get film delivered to them. And they were so angry they went on and on about it. And finally we got the PACS system put in, and what that did is it allowed they had a monitor in the ER. The doctor in the ER could contact and talk to the radiologist who was reading the X-ray, and so he got almost an instant consult. And they started to see the value of that. In fact, about 6 months later, we had to do an upgrade, so we had to take down that system for about 4 hours and use film. And the ER doctors went crazy because they didn't think they could practice medicine without the PACS system. So part of it is adaptation and understanding how those systems are better, can deliver better care. Now, health information systems should include a clinical information system, financial information system, laboratory information system, nursing information system, pharmacy, all the different parts, if you will. Include a picture archiving communication system, radiology system. All of those need to be included in that. Does computerization improve patient outcomes? And that's really the question. And none of the providers are using it to see the full benefit of computerization. I say providers in doctors' offices. We are seeing those benefits in hospitals, though, I believe. In that in hospitals, where the requirement is we use the computerization, we're starting to see a better result in that we don't see duplication of tests because if a patient goes from one healthcare facility to another, even within the same system, often their tests were being redone because there was no record of the original test. So that duplication is being avoided. And then we're starting to see a comparison of previous tests and new tests to see if there's any change, any delta in those two. And we're starting to see that that's being effective. So there are some studies showing improvement in the hospitals, but not completely because of that provider level in the private offices. In 2011, the Institute of Medicine announced that it would be conducting a one-year study to ensure that health information technology, HIT, will achieve its full potential for improving patient safety. If you remember, the Institute of Health in previous years, 2003, I believe, put out a paper that was very scathing of medicine, saying that medical error was very high and rampant in the healthcare system, and that they put in some precepts which were adopted by CMS, Centers for Medicare and Medicaid, that facilities would have to start doing those things to be paid Medicare money. And they changed even how we wrote prescriptions. We went from writing prescriptions to putting them on electronically, and then when we write a prescription in electronically, the system would compare what we'd given them, the medication we gave them, so see if there's any contraindications or to give it to somebody else or any crossover to other medications. So those, we're starting to see some benefits there. So the introduction to computer systems studies that do exist suggest that the most successful systems are created with the participation of those that use them. And we're finding that making customizable systems is important, and that's a big part of software is training and customization. So it matches the delivery of care, the location, the quality, the patient statistics that match that level, that the software does that. Systems imposed from above are not usually acceptable, and they're not very well done, and usually one size doesn't fit all, and that's the problem. So we're starting to see that customizable look being the real focus, and no matter what one you're looking at, there's several out there for different systems, for different areas of the hospital, that there are one system that fits the whole hospital, but it can be customized for each area. We're starting to see some benefits there. So we've completed this particular chapter, chapter 2, and this is we're done. Thank you very much.